actually. So it is my distinct pleasure to welcome you all to Grand Rounds this morning with Dr. Shekhar Pandey. I'm sure many of you know Dr. Pandey, who's been at our hospital for quite some time as a staff cardiologist, but also a cardiologist at St. Mary's Hospital with involvement with cathing. His practice is mainly in Cambridge at the Cambridge Cardiac Care Centre. Just by way of background, he grew up in Cape Breton, went to complete his BSc at Dalhousie University and his medical degree at the University of Toronto. He currently has appointments at the Department of Medicine at McMaster, the Ontario Drug Benefit Formulary, the Waterloo-Wellington Regional Cardiac Care Committee, and the University of Waterloo, and the Clinical Research Ethics Board. He is also a board member of the Kitchener-Waterloo Symphony. That's something I didn't know. That's awesome. Dr. Pandey is the founder of the nonprofit Prevent Clinic, a multidisciplinary high-risk prevention clinic focused on risk modification and lifestyle optimization. And included amongst his many awards and scholarships is the Rhodes Fellowship for Young Investigators with the International Society of Heart Research. And since 1987, he's authored over 60 peer-reviewed publications and abstracts in areas of heart failure, cholesterol, valvular disease, and organic mercury toxicity. He is also an editor of the daily online newsletter, the Cambridge Heart Healthy Daily. But I've known Dr. Pandey for quite some time, and I know in his free time he really enjoys being with his family, enjoys traveling, a variety of musical and visual arts, and obviously, I know that he does a lot of volunteer work. And in 2013, he started a charity named childtochild.ca and works each summer for 1 month at Mother Teresa's orphanage in India. So with that, Dr. Pandey, can I hand it over to you, who's going to provide us with an update on CHF, new therapies, new guidelines, and new strategies.
Thank you so much, Winnie. Thanks for that kind introduction. Just two corrections to that. So during the pandemic, unfortunately, we have not been able to go for the last 3 years to the orphanage. We're hoping this year that they will allow us to come to the orphanage to do some work again later this year. And I just finished my term with the board of the symphony, so but still actively involved. So I'm going to start. I'm hoping that this will present properly. Are you able to see my slides?
Yes, I can. Thank you.
Perfect. So thanks everybody for inviting me to present. Just looking to see if I'm getting control. These are my disclosures for this presentation. I think one of the most important disclosures is that I have been an investigator in many of the trials that we're going to be discussing today, which obviously brings bias because I am an investigator in some of these trials, but hopefully also brings a little bit of insight as to how the trials were conducted and how they have implications to our patient population. Our agenda is long, so I'm going to try to go through it quickly. A brief description of what is heart failure. We now have new categories of heart failure beyond what we used to think about with systolic and diastolic heart failure. Discuss what those new categories are, what the new therapies are for heart failure, what their potential impact can be, but also the need to overcome therapeutic inertia because we are seeing an underutilization of some of these novel therapies. And Dr. Nguyen asked me to present also on the outcomes from the Cambridge Heart Failure Clinic that was divested from the hospital to the Cambridge Cardiac Care Centre a few years back. So at the end, I'll present some of the outcomes data to date from that. So as a background, we all know the pathophysiology of heart failure. It starts off with some form of myocardial injury, whether it's myocardial infarction or ischemia, or other states like hypertension, diabetes, toxicities from chemo, viral toxicities, various injuries to the myocyte, leads to ventricular remodeling, which ultimately leads to impairment of muscle function, whether it's systolic function or diastolic function. At the same time, it can lead to electrical instability, which puts these patients at a great risk for both ventricular arrhythmias and sudden death, as well as a high risk for atrial fibrillation. As much as 40% of patients with heart failure have AF and are at a very high risk for strokes if they develop AF and do require anticoagulation at the time of diagnosis. All of this leads to neurohormonal imbalance, a rise in renin-angiotensin-aldosterone system, a rise in the sympathetic system, all of which are further deleterious to the myocytes, leading to a circular damage cycle of worsening ventricular remodeling. At the same time, natriuretic peptides do also increase, and we'll talk briefly about that they do actually have some potential benefits, and raising natriuretic peptides through pharmacological intervention can have benefits for heart failure progression. Heart failure is a growing epidemic in Canada, and it's an epidemic that leads to a very high utilization of the healthcare system. Over 60% of patients that present to the emergency department with heart failure are admitted, and the average length of stay in Canada is just under 9 days. When patients are admitted and discharged, they have a very high readmission rate. In fact, the highest readmission rate of any of the categories assessed in the ISIS Atlas recently, with over a 20% readmission rate across the province for anyone that is initially admitted within 30 days. It ends up costing the Canadian healthcare system almost $2.8 billion per year projected in the next few years. Historically, we've thought of heart failure as two major categories: left-sided heart failure with systolic heart failure, where the heart muscle itself had become weakened and was not able to pump with enough efficiency, where the ejection fraction has dropped, or a diastolic heart failure, where the heart muscle was thought to have become stiff and couldn't relax enough to allow blood to fill the ventricles and pump to the rest of the body. As well, we knew that there was right-sided heart failure that could occur from the right ventricle starting to weaken. That could occur either from primary pulmonary causes, causing a backup of pressure into the right ventricle and causing right heart failure, or left-sided causes where, again, a backup of pressure from the LV into the pulmonary circulation and then back to the RV could lead to our right-sided heart failure. So historically, that's how we've really thought about heart failure, but it turns out that heart failure is much more complex than that, and recently we've adopted new categories. At least historically, we used to think about systolic heart failure as the serious heart failure where the ejection fraction was poor, where the myocytes were failing, and that we thought that those patients would have a very poor survival. And historically, we thought of diastolic heart failure as the second cousin, where the myocytes were still working, but they were a bit stiff. They'd cause you to be short of breath. But we really didn't think that those patients died at the same rates or had the same serious mortality risk. Well, in fact, if you watch these patients and follow them over time, the mortality risk from both systolic and diastolic heart failure is exceedingly high. Diastolic heart failure patients die and have a mortality rate very similar at 5 years to those with systolic heart failure, although the causes of death may vary. And almost 50% of both systolic and diastolic heart failure patients today, even today, die within 5 years of their diagnosis of heart failure. So this is obviously a very serious disease in both systolic and diastolic impairment. Recently, however, both the Canadian Cardiovascular Society and more recently the American Heart Association have adopted new categories of heart failure because we do understand that there are different interventions for them. So what we used to call systolic heart failure, we now refer to as HFrEF, heart failure with reduced ejection fraction, where the LVEF, as measured by echo, MAGA, or cardiac MRI, is below 40%. What we used to call diastolic heart failure, we now refer to as HFpEF, heart failure with preserved ejection fraction, where the ejection fraction is within the normal range. EF is above 50%, but there is evidence for structural heart disease, either left atrial enlargement, left ventricular hypertrophy, and also evidence for increased filling pressures. Now that BNPs are readily available both at the hospital and are covered by OHIP for community measurements and community labs, BNP is a very important surrogate marker for increased filling pressure. As the filling pressure goes up, it stretches the left atrium and right atrium, which releases BNP, and is a good marker that there is increased filling pressures. Non-invasively, we can also measure filling pressures by echo, by increased RVSP, or invasively, either through Swan-Ganz catheters in the ICU or during cardiac catheterization. So the evidence for increased filling pressures with preserved ejection fraction is the hallmark of HFpEF. Most recently, in the last year, the AHA has introduced two new categories of heart failure with improved ejection fraction, HFmrEF. These are patients that previously had impaired ejection fraction. EFs were below 40%, but now with therapy, their ejection fraction is above 40% and sometimes well within the normal range. So they've introduced this category because we need to think about that, and there are new trials that suggest what we should do about these patients. and those that are in the mid-range. So remember, to have reduced ejection fraction, the EF had to be below 40%. To have preserved ejection fraction, you had to have an EF above 50%. So how about in between, 41 to 49%? So that's now felt to be the mid-range ejection fraction heart failure. And again, there are newer data to suggest therapies that may be beneficial there. So why did we include this mid-range ejection fraction? Well, we included it because a number of therapies that we've historically deployed for reduced ejection fraction heart failure, EF below 40%, actually turn out to be of significant benefit also in the mid-range, at least to EFs below 55%. So the first data that suggested this was with the ARNI Entresto sacubitril valsartan. And in the Paragon study, we saw that all individuals that had an EF below 55% seemed to benefit. Those well within the truly normal range did not have benefits by the introduction of the ARNI. So again, suggesting that perhaps mid-range EF heart failure behaves closer to reduced ejection fraction heart failure. Similarly, and more recently, SGLT2 inhibitors that have become hallmarks of heart failure therapy that I'll get into later have now been shown to have significant benefits in the mid-range ejection fraction heart failure population. This was first seen in the SCORED and SOLOIST study with an SGLT2 inhibitor that's not available in Canada, sotagliflozin, but did show significant benefits in the mid-range diabetic EF patient population. And more recently, about a year ago, the SGLT2 inhibitor empagliflozin or Jardiance that is available in Canada showed significant benefits in patients with preserved ejection fraction heart failure in the Emperor Preserve study. But when you look at the details of that study, much of the benefit really came, and the greatest benefits came in those that were in the mid-range where their ejection fractions were below 50% but above 40%. And we saw substantial benefits that started very early and continued to accrue within time. And I'll show you data later that we should really think about initiating these therapies while patients are still in hospital with their heart failure hospitalization. We now have compelling data of both safety and efficacy outcomes from in-hospital initiation. So the recommendations currently for mid-range ejection fraction, EF between 41 to 49%, is to diurese them effectively to achieve euvolemic status. But prior to discharge, think about starting them on SGLT2 inhibitors early because they have substantial reduction in heart failure progression, heart failure hospitalization, and mortality. And in some patients where blood pressure tolerates, introductions of ARNIs, MRAs, and if they've had previously reduced ejection fraction, selectively use beta blockers that we'll get into later. We've also introduced a new category called heart failure with improved ejection fraction. Why did we do that? Well, we know that some patients that have impaired EF below 40%, when we get them onto guideline-directed medical therapy, their ejection fraction can improve, and in fact can improve to well within the normal range. We've just not known what to do with these patients. Do we continue them on therapy? Do we take them off therapy with beta blockers and ARNIs? What should we do? And a lot of patients are keen to start thinking about reducing therapies, and historically we just didn't know what to do. There was a very important and actually very courageous trial that was done out of England. I don't think this trial could have gotten done in Canada and North America. I don't think it would get through my ethics board at the University of Waterloo. It was called the HFrEF study. So these were patients that had recovered dilated cardiomyopathy. All of them had impaired ejection fraction, and then they were randomized once their ejection fraction had normalized to continuing their background therapy versus withdrawal of their heart failure management. And what they saw is that this withdrawal strategy resulted in a very rapid and early deterioration of both their ejection fraction and the recurrence of heart failure in a large number of patients. Almost 50% of patients were back in significant heart failure within 6 months. So as a result, the guidelines are very clear now. Those that have had previously impaired ejection fraction but now have normalized their ejection fraction, even if they're asymptomatic and have ejection fractions well within the normal range, we should continue to maintain all of their background heart failure therapies because withdrawal of therapy can result in a recurrence of both LV dysfunction and recurrence of significant clinical heart failure. So this is a class 1 indication, a mandatory indication to continue background therapy even if patients normalize their ejection fraction and start to feel better. Moving on to HFpEF, those that have truly normal ejection fraction, EF above the 50-55% range. This represents at least a third to half of all cases of heart failure. To date, it has been poorly studied, and empiric therapy for management of symptoms was the primary goal until recently. And I'll show you data that suggests that perhaps we do now have therapies that can change the natural trajectory of this condition. Historically, as I said, HFpEF has been thought to be the second cousin, where patients feel short of breath, but really didn't have a high mortality rate. And we often ignored these patients or really looked at other things that they may be suffering from. But when you look at these patients, they have a very high mortality rate, very similar, in fact, to those with impaired ejection fraction heart failure. We just didn't understand or pay attention to it close enough to recognize just how serious their mortality risk is. And as I said, by 5 years, both reduced ejection fraction and preserved ejection fraction heart failure patients have almost a 50% mortality rate, less than half are alive at that point. They also have very high rehospitalization rates, again, very similar to the reduced ejection fraction heart failure population. So even though their EF may be normal, both their morbidity and mortality burden is very high, and they have marked impairment in functional capacity. Their exercise capacity is severely impaired. They have neuroendocrine activation with increased sympathetic drive, which makes them very tachycardic and symptomatic, and an impairment of quality of life. Very similar symptom complex to the reduced ejection fraction. Traditionally, HFpEF patients, we've really focused on just managing their signs and symptoms of heart failure, focusing on diuretics to get them to euvolemic state, using calcium channel blockers to control their ventricular rate from AF if they have it, to treat hypertension and manage their underlying disease state, whether it's ischemia or hypertension. And that's really what we did for many decades. Recently, however, there have been trials that suggest that we can actually change the disease state itself with certain therapies. The first therapies that suggested potential benefits were MRAs, mineralocorticoid receptor antagonists, so aldosterone antagonists. A first large trial that looked at this was called TOPCAT. This was a very controversial trial because it was conducted both in the Western world, in North America and South America, but also in Eastern Europe. And we saw a dichotomy in this population. Those that were in North America and South America behaved like traditional heart failure patients, had very high mortality rates and heart failure readmission rates. And in that population, we saw significant benefits by the addition of aldosterone antagonists, specifically aldactone. But in the Eastern European population, they had very low mortality rates and didn't seem to benefit. And when we went back and reanalyzed the data from Eastern Europe, it was really not clear whether any of these patients truly had heart failure. Their BNPs were very low, and a lot of the clinical findings that you would expect with heart failure really wasn't present when they were audited. So it suggested that perhaps the data from Eastern Europe may not have been reliable, and many heart failure specialists will just really look at the North American, South American data, suggesting that MRA antagonists may have benefits in the HFpEF population. There are now 3 large trials ongoing to validate this hypothesis, both with aldosterone, and now there are newer non-steroidal MRAs that have less risk of hyperkalemia and less mammary irritation that are also being looked at in this population. Beyond that, again, SGLT2 inhibitors have been game changers in heart failure. They started off as diabetic drugs, but actually turn out to have much of their benefits from heart failure reduction. And in the HFpEF population, I showed you this trial for the mid-range, but the same mid-range evidence exists for the HFpEF population. SCORED and SOLOIST with sotagliflozin showed significant benefits in diabetics with HFpEF, a significant reduction in both mortality and heart failure hospitalization in this trial. This molecule is not available in Canada, but the other SGLT2 inhibitors that are available seem to have the same types of benefits. I showed you the data from the Emperor Preserve study, and again, we saw a remarkable reduction in both heart failure hospitalization, progression of disease state, as well as cardiovascular death, just over a 20% reduction very quickly. The curves start to separate within weeks of initiation of the SGLT2 inhibitors and continue to separate with time. The longer patients are adherent to it, the greater the benefit. So the recommendations now for HFpEF management, those with truly normal EF, is to, again, try to achieve euvolemic state with diuretics as required. SGLT2 inhibitors now have a 2A indication. There's another trial called DELIVER that we were part of that we'll be presenting later this year. It is a positive trial. Once that comes out, the SGLT2 inhibitors will likely get a class 1 indication for addition in the HFpEF population. Beyond SGLT2 inhibitors, MRAs have compelling data and more data to come. And again, ARNIs and ARBs may again have benefits in this population. So moving on to thinking about spectrums of HFpEF, one of the things that we have actually realized recently is that a significant number of HFpEF patients may in fact have amyloid heart disease. So as you know, amyloid is an abnormal protein that deposits into the myocytes as well as other organs and can cause myocyte dysfunction. It causes unexpected and severe left ventricular hypertrophy. So in patients that have severe left ventricular hypertrophy of unexplained causes, particularly in older population, and particularly if they have other systemic features like chronic renal failure, claudication, peripheral neuropathy, patients with carpal tunnel syndrome. These can all be signals that perhaps they're depositing these abnormal proteins both peripherally but also into myocytes. And in that spectrum, it is recommended as a class 1 recommendation that we should be screening for amyloid heart disease, both for multiple myeloma-induced amyloid heart disease, where we should be screening serum and urine immunoelectrophoresis to see if they potentially have amyloid from multiple myeloma, where treatment of multiple myeloma may have benefits, and more recently, now that there is a therapy for ATTR primary cardiac amyloid, PYP amyloid heart scans that are done at Cambridge Memorial Hospital in the nuclear medicine department can allow us to detect these patients with a very high sensitivity and specificity rate. And now tafamidis is a therapy that has become available and covered in Ontario for our patients with amyloid heart disease that is caused by ATTR. So we want to start screening these patients if there's unexplained hypertrophy with HFpEF and peripheral manifestations such as neuropathies or carpal tunnel syndrome or renal failure or other systemic features to suggest that this is a systemic process. In that population, we now have compelling therapies, both for ATTR primary cardiac amyloid as well as for amyloid that results from multiple myeloma. Moving on to the HFrEF population, what we used to call systolic heart failure. We really break systolic heart failure, HFrEF, into two large categories, non-ischemic cardiomyopathies and ischemic cardiomyopathies. We categorize it that way because non-ischemic cardiomyopathies, whether it's due to hypertension, metabolic disorders, toxins, or idiopathic, behave very similarly and respond very similarly to therapy. Whereas ischemic cardiomyopathies, it is crucial that we detect that and consider revascularization if the option exists. That data on the need for revascularization of ischemic cardiomyopathies is actually quite old. It dates all the way back to the CAS registry from the mid-1970s, where they showed that surgical revascularization of an ischemic cardiomyopathy patient has significant benefits above and beyond best medical therapy. This has been validated even in more modern times with the STITCH trial that came out in the mid-2000s, again suggesting even with modern heart failure therapy, surgical revascularization does seem to have significant mortality and morbidity benefits in ischemic cardiomyopathy patients. Unfortunately, PCI and stenting does not have the same benefits as surgical revascularization for heart failure patients with ischemic cardiomyopathy. So if they have multivessel disease as a cause of their ischemic cardiomyopathy, preferentially they should be considered for bypass surgery. And the mortality reduction may be as much as 50%, at least in the CAS registry, perhaps less with modern therapy, but a significant benefit from early revascularization. So that's the reason we really stress detection of ischemic heart disease in this patient population, consideration for early angiography and revascularization where required. Certainly in terms of medical therapy, traditionally our medical therapies have consisted of ACE inhibitors and beta blockers, which did above background diuretic therapy show significant benefits in various trials, and then MRAs, both aldosterone and eplerenone, on top of beta blockers and ACE inhibitors have further significant benefits. This has been the traditional triad for 2-3 decades, and there was really a stagnation of heart failure therapies. And so up until at least 2015, background therapies consisted of ACE inhibitors, beta blockers, and MRAs. And where required, patients were getting defibrillators. In the African-Canadian population, hydralazine nitrates do have benefits, and we use digoxin where required for symptom control only. There was really no progress in heart failure management for 2-3 decades until the mid-2015 range. In 2015, early 2013, data started to come out with a novel therapy at the time, ARNIs, angiotensin receptor blocker, neprilysin inhibitor. There's actually only one molecule in this class, a combination pill of sacubitril valsartan. So valsartan is an ARB, an angiotensin receptor blocker, and sacubitril is a neprilysin inhibitor. So neprilysin is also known as neutral endopeptidase, and neutral endopeptidase break down a number of enzymes that are circulating in the bloodstream. Importantly, they break down enzymes that are actually beneficial for the heart. BNP, bradykinin, and adrenomodulin are hormones that circulate that have very favorable effects on the heart. They cause peripheral vasodilation, they reduce the sympathetic nervous system, and they result in natriuresis and diuresis, a number of benefits for the heart failure population. And when combined with the angiotensin receptor blocker, it would seem to make a lot of at least biological sense that they may have benefits beyond what an ACE inhibitor alone could provide. We did a trial with this at the Cambridge Cardiac Care Centre prior to the large randomized trials, looking at the impact of this on left ventricular ejection fraction. And what we showed that patients that were switched from ACE inhibitors to the angiotensin receptor blocker neprilysin inhibitor, sacubitril valsartan, had significant improvements in their ejection fraction, suggesting that myocytes were responding well to this combination therapy. After that, the landmark Paradigm HF study came out, where patients had been randomized to either background ACE inhibitor therapy or, at the time, it was called LCZ696, now known as Entresto, sacubitril valsartan, and we saw significant benefits, a 20% risk reduction with a p-value with lots of zeros in front, suggesting high statistical significance, suggesting patients can have both a reduction in cardiovascular death as well as the risk for hospitalization. Recently, a very important trial came out called Pioneer HF that looked at the early initiation of angiotensin receptor blocker neprilysin inhibitor, sacubitril valsartan, compared to continuing patients on ACE inhibitor therapy while they're in hospital. And this trial showed a significant reduction in BNP with the switch over from ACE inhibitor to ARNIs while patients are in hospital, but also a very important secondary endpoint, reduction in hospitalization, death, the need for advanced therapies like listing for transplant, and that benefit again starts to occur very quickly and continues to accrue the longer patients remain on background therapy. So this recommendation now from the Canadian Cardiovascular Society and Canadian Heart Failure Society is when patients are hospitalized with heart failure prior to discharge, their ACE inhibitors should be switched over to ARNI because it will, one, help to reduce rehospitalizations, and two, have significant and early mortality and heart failure progression reduction. SGLT2 inhibitors, we've talked about a number of times, have also now been studied in the HFrEF population, those with ejection fractions below 40%. And the first landmark trial to show this was called DAPA-HF with dapagliflozin or Forxiga, and showed almost a 30% relative risk reduction, with curves starting to separate very quickly, and the longer patients remained on SGLT2 inhibitors on top of best medical therapy, the greater the benefits were accrued. So suggesting that this should be a background therapy as part of the foundational therapies for heart failure management. Again, recently, there's been an important trial looking at the early initiation of the SGLT2 inhibitors while patients are still in hospital. The MPulse study looked at empagliflozin or Jardiance and showed a 36% clinical benefit when patients were initiated in hospital with the SGLT2 inhibitor, with a significant reduction in both rehospitalizations, time to death, heart failure progression, as well as significant improvements in patient-reported symptoms as measured by the KCCQ score, which is a validated score for patient symptoms in heart failure. So empagliflozin had substantial benefits from early introduction beyond waiting till patients get home. And the recommendation now, again, from the Heart Failure Society is patients should be started on the SGLT2 inhibitor just prior to discharge or while they're still in hospital. This can, one, reduce the need for high-dose diuretics, but also have significant further benefits. And there has historically been concerns about using SGLT2 inhibitors while in hospital. Could it cause acute kidney injury? Could it lead to ketoacidosis or euglycemic ketoacidosis? Importantly, all of those concerns were allayed in this trial. In fact, renal function was better in those that were randomized to the empagliflozin arm compared to those that continued on placebo while in hospital. There were no cases of ketoacidosis. There was no increase in UTIs. So really a very remarkable safety profile from early initiation of SGLT2 inhibitors while patients are still in hospital. And the recommendation is now that patients, once they start to diurese and are getting close to euvolemic state, 1 or 2 days prior to discharge, patients should be started on the SGLT2 inhibitor. This will reduce their risk for rehospitalization and have a significant benefit compared to continuing on background therapy, and delaying it till the patients get home can result in further rehospitalization risk and further progression of background heart failure risk. So the 4 pillars for HFrEF therapy, as recommended by the Canadian Heart Failure Society and CCS, really are for all of these patients to be on maximally tolerated background therapy with beta blockers, ARNIs, sacubitril valsartan, MRAs like aldactone or eplerenone, and the 4th pillar is the addition of SGLT2 inhibitors in Canada, dapagliflozin and empagliflozin, and every time patients are assessed either in primary care by their primary care provider, by internists, by hospitalists, or by specialist clinics, they should be optimized and the doses should be maximally increased to get them onto optimum doses. These patients will tolerate very low blood pressures, so as long as their blood pressure remains above 95 to 100 systolic, we should continue to try to optimize and increase the doses of these therapies, because maximally tolerated therapies have substantial benefits beyond continuing their background therapy, and that benefit is very quick and rapid. So if patients are on no background therapy for HFrEF, their 2-year mortality is 35%. 1 in 3 are dead within 2 years, 50% at 5 years. The addition of sacubitril valsartan or ARNIs reduced that mortality down to 25% at 2 years. Introduction of the beta blocker further reduces that mortality down to 16%. The introduction of MRAs brings that mortality down to 11%, and the 4th pillar, SGLT2 inhibitors, further reduce that mortality down to 9%, going down from 35% all the way down to a 9% mortality within 2 years. The relative risk reduction for mortality is 73%, with an absolute risk reduction of dying of 25%. We require to treat only 4 patients with this quad therapy strategy to save 1 life at 2 years. So the benefits are dramatic and substantial, and early initiation of these therapies with up titration every time the patient is seen in primary care, in hospitals, in specialty care settings. Their doses should be aggressively up titrated as required. Unfortunately, there has been a therapeutic inertia. This has been noted both in Canada and the US. This is CHAMP registry data from the US, but the same type of data exists in Canada, that patients unfortunately are not getting on to optimum therapy. In the CHAMP registry, which came out a couple of years back, we saw that there was a very poor utilization of background optimum therapy, with less than 1% of patients being on all 4 classes of therapies at baseline. But even a year after they had been diagnosed with heart failure, the uptake of these background therapies still remained very poor, with less than 5% of patients being on ARNIs and less than 30% being on beta blockers, MRAs. So really a big care gap that exists. This led us to develop the multidisciplinary heart failure optimization program. This was a divestment from Cambridge Memorial Hospital, and we incorporated cardiac rehabilitation, and I'll talk to you about that and show you some of the data that Dr. Nguyen had asked me to present from this divested program at Cambridge Cardiac Care Center. So this was a program developed in concert between the Cambridge Cardiac Rehab program in conjunction with the Cambridge Congestive Heart Failure Clinic. At the top are the members of the cardiac rehab team, as well as at the bottom the CHF clinic team that consists of nurses, pharmacists, background support by cardiology. We've been collecting this data now for the last 3 years. We actually initiated this program just prior to the pandemic, and throughout the pandemic, it's continued. We presented this outcome data at the Canadian Heart Failure Society earlier this year, and it's going to be presented in a more robust fashion at the European Heart meeting in Barcelona in August. And there's a paper in pending publication in the European Heart Journal. So this strategy really in our system centers around the crucial role of cardiac rehabilitation in heart failure patients, and I'll talk to you a little bit about that. Cardiac rehab patients, individuals often think, oh, it's just a fancy gym. Cardiac rehab is much more than a gym. It is a chronic disease management system for self-care, self-support, education, risk factor optimization, exercise rehabilitation, as well as management of mental health concerns, depression, and anxiety. More than a third of patients with heart failure have significant depression and anxiety as a contributor to their symptom complex, and managing that as an important part of improving their symptomatic outcomes. So cardiac rehab has been the anchor to our program. We know that exercise has significant benefits in heart failure patients. It has direct cardiac benefits, improving myocyte function. It has good peripheral benefits, both to the renal system as well as the large muscle group system. It has primary respiratory benefits, and it has neurocognitive benefits from early introduction of exercise rehabilitation. Cardiac rehabilitation has been well studied in heart failure patients and reduces the risk of dying by between 20 to 25%. And it reduces rehospitalization by over 40% within 6 months on top of best medical therapy. Unfortunately, it is underutilized in Canada, with less than 10% of heart failure patients participating in cardiac rehab. 90% are never referred to a rehab program. This perhaps could change with the introduction of virtual cardiac rehab. Some of the holdups have been these are often elderly patients that struggle to come on site and get transportation to come on site for rehab. An important study came out a couple of years back looking at the potential for virtual cardiac rehab, home-based interval rehab training in heart failure patients. And this paper that was published in the Canadian Journal of Cardiology showed that virtual cardiac rehab may have similar efficacy as to standard on-site cardiac rehab and can increase the reach of cardiac rehabilitation programs to a larger population, some of whom may not be able to come on site because of transportation or other limitations. So by adopting that, perhaps we can reach a larger group of patients. We again did a small trial at our own center looking at the impact of virtual cardiac rehab with reminders on medication adherence. Not only does it improve their functional capacity, but patients that participate in cardiac rehab have significantly higher rates of medication adherence compared to those that do not participate in cardiac rehabilitation. All of this background data led us to develop a novel program of CHF optimization with a hybrid virtual and on-site cardiac rehab. We actually had started this prior to the pandemic, and we were fortunate that we already had a virtual program in place. And so when the pandemic hit, we were able to pivot quickly, and the full rehab and heart failure program switched to a virtual mode. All of these patients, now that things are starting up again, receive either on-site cardiac rehabilitation or virtual cardiac rehab through OTN, Zoom, FaceTime, or even just phones, with support by both nursing staff and kinesiologists, depending on their ability or access. All participants receive educational sessions either on-site or through Zoom-based sessions on diet, exercise, smoking cessation, stress management, and medication education. The patient flow, these patients are often referred to from the emergency department or from primary care, with some being referred while they're in hospital from specialists, hospitalists. They're seen within 2 weeks of their referral by the heart failure nurse and with background cardiology support. Then they start seeing the nurse every 2 weeks for medication optimization, and they start meeting the kinesiologist either virtually or on site once a week, with the goal for them to achieve maximal tolerated therapies of the 4 pillars as identified by the CCS of heart failure therapy. And the goal is to get them there within 3 months. This is the sequence through which our medication optimization program goes. At week 1, when they're seen, they're often switched over if they're not already on ARNI and an SGLT2 inhibitor is started. We start with that because ARNIs and SGLT2 inhibitors have diuretic-like properties, and often these patients still are volume overloaded. So by starting these therapies early, we reduce the need for diuretics and can start the optimization program early. They start exercise rehab at week 2. At week 3, beta blockers are added in. They continue exercise rehab weekly, and by week 5, we've introduced MRAs with appropriate background blood work testing as required. And the goal is for patients to have up titration of their therapies every 2 weeks and to try to achieve maximally tolerated therapy within 3 months. We also started an IV Lasix program at the heart failure clinic prior to the pandemic and continued through the pandemic with the goal to treat these volume overloaded patients in clinic, reducing the need for ER visits or transfers to ER. The exercise rehab program itself consists of starting off with a 6-minute walk test to see what their functional capacity is. Then they start either weekly or virtual on-site rehab with the kinesiologist. They receive educational content either on-site or through Zoom lectures. The initial exercise prescription is between 60 to 80% of symptom-limited target heart rate. By week 5, patients start light resistance training using free weights. The core program of weekly rehab continues for 12 weeks for 3 months. At the 3-month mark, a 6-week walk test is done to see what the impact of this is and to develop a new exercise prescription for them. And there is the option for patients to continue to a 1-year continuation extension program where they continue to come once a month for exercise rehabilitation. I'll show you the results in the first 532 patients that went through the program. As I said, this started just prior to the pandemic, and we continued the program virtually throughout the pandemic. The heart failure program and the rehab program did not stop at any point, and there was no reduction of services even at the peak of the pandemic. And we saw that the nurses have done an exceptional job in my mind. At baseline, when patients were referred, less than 2% were on background in sacubitril valsartan ARNI therapy, and by 3 months, 96% had achieved ARNI therapy. Beta blockers were actually well utilized prior to referral. 65% of patients were already on beta blocker therapy, but by 3 months, 85% had achieved baseline beta blocker therapy. Some of the limitations of beta blocker therapy included patients with asthma or advanced COPD, or those that were substantially bradycardic and couldn't tolerate the introduction of beta blockers. MRA use is poor in the community, but in this program, we were able to improve MRA use to just under 60% by 3 months. And when SGLT2 inhibitors became part of the background therapy, we were able to achieve over 75% of patients were on SGLT2 inhibitors at the 3-month follow-up mark. So by the 3-month, just under 40% of patients had achieved all 4 pillars of background therapy with beta blockers, ARNIs, MRAs to maximally tolerated doses. This compares to less than 1% in the CHAMP heart failure registry from the US being able to achieve background maximal therapy. There were limitations, as said, some patients couldn't get onto beta blockers either due to bradycardia or asthma or COPD that was quite advanced and didn't tolerate beta blocker introduction. As well, MRAs and SGLT2 inhibitors, as part of their product monograph right now, still have a contraindication in those with significant renal impairment, eGFR below 30, although that contraindication will likely be lifted because there are now trials in patients with renal impairment with both MRAs and SGLT2 inhibitors, and there will be greater utilization in that population as well. We also initially struggled with getting SGLT2 coverage for those that were not diabetic because some of the private payers only consider SGLT2 inhibitors as diabetic drugs, and if they weren't diabetic, we did struggle to get them covered. Again, some of those limitations will be lifted with time. These were very sick patients. They were often referred from either ER or from hospital. And during the course of their monitoring, 25 or 24 patients did have to be transferred from the heart failure clinic back to ER for therapy that couldn't be delivered there. But we also avoided hospitalization by an ER diversion program with 78 patients coming into clinic for either oral diuretic increase or IV Lasix, as I'd mentioned. And there were a smattering of other adverse events during the course of monitoring. In terms of the cardiac rehabilitation, over 60% of patients participated in cardiac rehab in this program, with over 58% participating for the full 1-year duration of the rehab program. And we saw significant improvements in functional capacity in those that participated in cardiac rehab. In heart failure patients, this is measured by a 6-minute walk test. And at baseline, these were very impaired patients, only able to walk 307 meters. But by 1 year, there was over a 25% improvement in functional capacity by the 6-minute walk test, improving to 372 meters. There was also a significant improvement in patient-reported symptoms as measured by the Borg RPE scale, again, a validated scale of symptoms with exertion in heart failure patients. And we saw that at start, there was a very high symptom burden with a Borg score of 11.6. And by a year, there was significant benefits with the Borg score dropping down to 10.4. So both symptomatic and functional capacity improvements as well as optimization. So in our hands, we really believe that the pillars of heart failure therapy consist not just of the 4 pharmacological therapies of beta blockers, ARNIs, aldosterone antagonists, and SGLT2 inhibitors, but also that cardiac rehabilitation should be added in for the vast majority of these patients, either virtually or on site. And whoever is managing the patient, whether it's primary care, hospitalists, internists, other specialists, we should use any opportunity we can when we're seeing these patients to increase these background therapies. We need to get them onto maximally tolerated therapies. The sooner the better. The mortality benefits, rehospitalization benefits are quick and rapid, and delays in optimization can result in adverse events. Other therapies that you may see heart failure patients receiving, if they remain tachycardic with heart rates above 70, ivabradine is an IF channel blocker that is used to reduce sinus rates below 70. It reduces sinus activity. It has no AV nodal properties and has significant benefits in this population. Those with wide QRS complexes, CRT therapy, cardiac resynchronization therapy with biventricular pacing has again been shown to reduce both morbidity and mortality. If they develop atrial fibrillation, they should be anticoagulated early. They're at a high risk for thromboembolic events. These patients are sometimes iron deficient, and there is good, compelling trial data now suggesting that iron infusion programs, particularly in hospital and severely anemic patients, may be of benefit. And those that have developed severe functional mitral regurgitation, where the mitral annulus has been stretched and are now getting severe MR due to left ventricular dilatation. There is now good data on mitral clip procedures that are done percutaneously to tighten up the mitral valve and reduce MR and have significant morbidity and mortality benefits. In the African Canadian population, hydralazine nitrates have also been shown to be of benefit. So beyond the 4 or 5 pillar therapies that I've suggested, there are other therapies that can be considered. In all patients that are on optimum background medical therapy, if their ejection fraction remains below 35% when they're reassessed, they should be considered for ICD, implantable cardiac defibrillators, because they are at a high risk for sudden death. And ICDs in that population have been shown to significantly reduce mortality risks. So to conclude, I just want to review the top 5 takeaway messages from the new data that's come out with heart failure. We know that guideline-directed medical therapy, both from the Canadian guidelines from the Canadian Heart Failure Society and the Canadian Cardiovascular Society, suggest that HFrEF patients, those with ejection fractions below 40%, should be on maximum tolerated doses of 4 classes of therapies: ARNIs, sacubitril, valsartan, beta blockers, specifically carvedilol, bisoprolol, or metoprolol, MRAs and SGLT2 inhibitors, and whoever is managing the patient should up-titrate those therapies at every contact as long as they're tolerated. If it's a struggle to get them onto therapy, they should be referred to heart failure programs where these therapies can be initiated and up-titrated as required. SGLT2 inhibitors now have a recommendation, a class 2A recommendation, in heart failure with mid-range ejection fraction and heart failure with preserved ejection fraction. And there are conditional recommendations for MRAs and ARNIs. There are ongoing trials that may move that up to 2 or class 1 recommendations. Those that have improved their ejection fraction after therapy, patients that had reduced ejection fraction previously, EF below 40%, but now with therapy have got their ejection fraction back into the normal range. These patients should not have their heart failure therapies reduced or discontinued. They should continue their background therapy because there is a high risk for heart failure recurrence and LV impairment very rapidly within 6 months. So background therapy in the improved ejection fraction heart failure population should be maintained lifelong. And finally, cardiac rehabilitation confers both morbidity and mortality benefits and should really be offered to all heart failure patients early. And at this point, I'll open up to any questions that there may be.
Thank you to Dr. Kearney. That was a lot of information and lots of updates since the last time that I guess you inform this group. So I do see a chat question if I don't know if you see it, but I'll read it out for the group. So Dr. Batra had asked, do you have data on management of HFrEF due to chemical cardiomyopathy, and in particular anti-HER2 or anthracene exposure in cancer population?
Yeah, great question, Anu. There is some data. Certainly, registry data has suggested that patients that are put on beta blockers and ACE inhibitors do have some improvement in both functional capacity and ejection fraction. I'm actually aware of 3 trials that are ongoing right now that are specifically looking at it in that population. But background registry data or data from some of the randomized trials where anthracycline-induced cardiomyopathies were included does show some benefits in that population.
Thank you. Just looking to see if there's any other hands for questions. I guess I have 2 questions, if that's okay. I was quite interested in the amyloid, the association of the amyloid and the cardiomyopathy. You mentioned that we do it in nukes. How often do you see that being referred for that specific reason, now that there's more education or knowledge around amyloid?
Yeah, I think it has been under-investigated. The registry data from the States would suggest that as much as 20% of HFpEF patients may have cardiac amyloid, either due to multiple myeloma or due to primary cardiac amyloid, ATTR amyloid. Historically, there wasn't really good trial data to suggest that there was benefits from treatment, so we didn't really investigate it because we didn't do very much about it. But now that tafamidis has become available in Canada for primary cardiac amyloid, ATTR, and it is covered by special use forms, that should now become a standard investigation in patients, particularly in an older population with unexplained significant hypertrophy, if they have other systemic features. If they have, for example, carpal tunnel or peripheral neuropathy or concomitant renal impairment, all of those can be clues that perhaps they have a systemic process where they're starting to deposit these abnormal proteins both into the peripheral circulation as well as into the heart. And cardiac amyloid or PYP scans are readily available both at CMH and really at, I think, all of our regional hospitals. So where the suspicion exists, it's I think not a particularly expensive test. It's a pretty quick test, and it has a very high sensitivity and specificity rate. So I was actually amazed by the data. It has a sensitivity specificity of over 90% for ATTR cardiac amyloid. But we also need to exclude multiple myeloma, and we've sent a number of patients to the oncology group where their immunofixation or urine immunofixation might be borderline or abnormal, to get their thoughts of could there be a multiple myeloma component, because certainly treating multiple myeloma may also have benefits. So I think we do need to expand the utilization of PYP scans in this population. If there's unexplained, if they don't have a history of hypertension, they're not diabetic, they don't have sleep apnea, there's nothing else that can explain their severe hypertrophy, we really should be thinking about screening for amyloid, because maybe as much as 20% of these patients could have that. And now we have very effective therapies that can change the outcome of that disease.
And you're not seeing it picked up on the other imaging. I'm thinking more cardiac MR, that you're not picking it up that way.
Cardiac MRI does not seem to have the same sensitivity and specificity for ATTR, and unfortunately, access to cardiac MRI is actually much more difficult. So PYP scans are readily available and actually seem to have almost the same sensitivity as cardiac biopsy for picking up cardiac amyloid. It seems to be very specific for ATTR cardiac amyloid.
That's great. Thank you for that. I see a hand up from Augustine.
Yeah, hi, Shaker. Thanks for the third review of the updates on heart failure management. I think the pillars you show for the heart failure management, I think 2 of them go back a ways, and we're, most of us as internists are aware of the the MRA and the beta blockers. The other 2 pillars obviously are somewhat newer, and the adherence, or at least the what you present in terms of switching the therapies to these now well demonstrated to improve morbidity mortality outcomes is lagging, and some of that obviously is education, and some of that I suspect maybe a comfort, right? And as you know, within our hospital, the vast majority of our heart failure patients are taken care of by our very busy hospitalists in internal medicine and ICU teams, and perhaps this is not one part of the algorithm that they're not quite incorporated into practice within that. And I suspect that there may be some of that in terms of the lag in terms of implementing these therapies. The other is perhaps follow-up. Now, they do come with some potential side effects and complications. So that's sort of, I think, the other thing that may be holding back, shall we say, the implementing of these newer therapies, whereas people are much more comfortable starting somebody on a low dose of a beta blocker or 25 milligrams spironolactone. Those are just, standard therapy that's been used for many years. So I guess what I'm getting to is obviously the long and medium long-term outcomes, morbidity, mortality is well documented. I'm interested from the hospital standpoint of sort of reduce readmissions and length of stays. I think are two of our primary goals in sort of our priorities now. And the question I have really is how do we support our primary physicians, the most responsible physicians for these patients in the hospital, to make these changes aside from the protocols that are there, and then what are the supports should we be doing to encourage these newer therapies and hopefully get them on these therapies before they even get to the heart failure clinic. Well, what is there any evidence out there that what are the good strategies we can use? Is it the pre-printed orders? Is it cardiology support? Is it insurance of a specific heart failure clinic follow-up? Those types of strategies, and what has anything been shown to work, or what can we do?
Yeah, thank you. Those are excellent questions. So, the care gap exists not just in our jurisdiction, but really worldwide. I showed you CHAMP data from the US, where they struggle just as much as we do. So, I think it is an all hands on deck strategy, because the benefits are very quick and early. You see mortality reductions by early initiation, but also significant morbidity reductions and rehospitalization. And rehospitalization is such a high burden for these patients. It's a huge cost to the system, a cost to the hospital. So certainly the earlier these therapies can be initiated, the better. There was, quite, as you said, important initial hesitation, because we didn't have data that you could initiate these drugs safely while they were in hospital. SGLT2 inhibitors, people wondered, is it going to cause euglycemic DKA in this population? But what we've actually seen, and in these large trials that I showed you, that these drugs can be initiated safely and in fact have lower side effect profiles. So patients that are started on SGLT2 inhibitors in hospital, for example, have lower rates of hyperkalemia and better renal protection than those that are just maintained on diuretics. So certainly getting that knowledge base out there that these drugs can be initiated safely and have very early benefits, can reduce that 30-day rehospitalization. I think that's an important part of that. So education, as you said, is obviously key, and that's why you asked me to put on these grand rounds. But beyond that, I think pre-printed order sets, we need to look at updating our heart failure order sets. The Canadian Heart Failure Society has actually come out with now national order sets that I'm going to try to bring back to our internal medicine group to review, because I think we should be updating our order sets to align with the national order sets that the Canadian Heart Failure Society has developed. And certainly, part of the order sets actually also suggest that patients, when they're hospitalized with heart failure, should automatically have a referral to one of the regional heart failure programs, either at our center, at St. Mary's, or at Hamilton General. Those would be the three regional programs that would be accessible to our patient population. And so an automatic referral to these programs should be considered and are part of the order set. The uptake of the order set has been less robust, both at our hospital and elsewhere, but I think we need to try to develop a support system, both for patients, so that they have a landing spot after their discharge, so they're not waiting weeks and weeks, If they're waiting to get into cardiology, it might be many months before they see their cardiologist. So getting to see a heart failure nurse early post-discharge within 1 to 2 weeks can help to support those patients. They can be started on those therapies in hospital and blood work be done and followed up by the heart failure nurse early so that there is support and background for that. So, thanks for that question. I think it is really an all hands on deck. And I think, the benefits both for the hospital in terms of heart failure readmission reductions, the cost to the system, but obviously to the patient, early mortality benefits and symptom relief can be achieved by getting these patients onto therapy.
Thanks for the question. Thanks, Dr. Pendy. I see Mark Schaefer's hand up. If hand it over to you, Mark.
I think Mark is still muted.
Yes, I think Mark, you're muted. I just saw his hand come down.
Yeah, I'm not sure.
Maybe it was, yeah, I'm not sure.
Sorry, it's Mark. Was that, I got booted out all of a sudden at 9 o'clock.
Oh, I didn't realize that.
Sorry. So yeah, I don't know if it's you or me. I just at 9:00, I just got booted out. So I just got back in. So my hand was up. Is that what you were just saying?
Yes.
Yeah.
Yes.
I wanted to follow up on Augustine's comment about the PPOs, which of course is, having sat on M&T and back on M&T, I'm all for our policies and procedures that help support standardization of care. We do not, and in no way is my next comment to denigrate our hospitalists, who I know are simply completely overwhelmed right now. But we do not currently have a CHF NP, is that correct?
No, we do not.
So would there be a cost benefit for our hospital having a CHF NP who can help with these patients? And maybe if they have more time than just CHF, other cardiac or COPD related stuff as well. But is there some benefit for some upfront costs to have some specialty support for our cardiologists and our hospitalists, with new complex, process and evolving processes?
So that's an excellent question, Mark. There was actually a study that looked at that from Europe that showed that hospitals that have an NP for in-hospital heart failure management had lower readmission rates and better guideline-directed medical therapy. So, it is definitely something where, there can be both a cost benefit and a patient benefit from that type of support. As you said, there is upfront costs, but then the costs to the hospital overall from a reduction in rehospitalization and utilization might be beneficial if we could support an NP that could perhaps do both heart failure in hospital assistance, but also perhaps COPD management, because there's often an overlap, and they also have very high readmission rates. So perhaps a two-pronged strategy.
Yeah, and I'm not trying to denigrate Loretta McCormick, who's our current COPD nurse and does a great job seeing those patients, but I know she's overwhelmed as well. And I'm sure that Winnie has her, service resumption and surgical backlog issues at hand. So the more beds we can keep open for those things, the better. Anyway, thanks. Thank you very much, Shaker. That was a great talk.
Thanks, Mark.
Thanks, Mark. And that's a great takeaway, Mark. Just kind of to digest things that we can do in hospital to improve that, that journey and prevent readmissions, and also optimize the care beyond the hospital. So with that, I know we went a few minutes late, but that's always a great sign. Lots of questions, lots of things to take away. On behalf of the group, I just want to, special thank you to you, Shaker, to take the time in your morning to present to us and update us on management of CHF. So thank you very much.
Thanks so much, guys. Have a good day. Enjoy this gorgeous day.
Have a great day, everybody. Thank you.